Hello, good morning. I think I'm the only person here without the letters DR, PROF, REV before my name. I am just plain Rachel Lane, no Doctor, Professor or Reverend before me. I'm an expert patient tutor as part of the medical school here. And this is Gina Hadley, who is Dr. Gina Hadley, it's our clinical neurology fellow. And we're going to talk to you today from the perspective as medical educators within the medical school and specifically within the neurology department. Medical school is hard, it's supposed to be hard, and we lose students before they've even really gotten started. And we want to know, what can medical schools do to mitigate that risk of losing good doctors before they've really even gotten going? So our perspective is neurology, and within neurology, there is such a thing as neurophobia. Gina's going to describe what that is.
So Rachel and I are going to tell you our story this morning. So first of all, we have to define the problem in neurology, and that problem is something called neurophobia. This is a phrase or a term that was coined in 1994 by Josefowicz. And neurophobia is the fear of neurosciences and clinical neurology that is due to the student's inability to apply their knowledge of the basic sciences to clinical situations. So, the idea behind how we tackle this should be credited to Professor Gabriel De Luca, who chaired the first session on Tuesday evening. And he's a consultant neurologist at the John Radcliffe and a professor of neuropathology and clinical neurology. And he took over the course in 2016 of the medical students learning neurology at Oxford Medical School. And he started from asking three basic questions. Is it neurological? Where is the problem? And what is the problem? And he wanted to design a patient-centered, relationship-based, experiential learning program in order to answer these three questions and improve the competence and confidence of our foundation doctors. And foundation doctors is the equivalent of the interns that you have in the States. And the reason behind this is not to churn out lots and lots of neurologists. It's actually to make the generalist competent and confident with neurology as well. Okay.
So we involve the patient, and within neurology that's important because many neurological conditions have invisible symptoms. Now mine right now, I have MS, is very visible, you can see that. But when I first was diagnosed, you wouldn't have been able to tell. Whether it's memory issues, whether it's fatigue, whether it's sensation changes, it might be the creeping loss of mobility that starts as bothersome and becomes debilitating. These things are not visible to the naked eye. And so doctors need patients to be involved and talk to them. I can't read that properly from here. There is perhaps no branch in practical medicine in which the help and cooperation of the patient is so essential as in the approach to a neurological disorder. For in the first place, it is on the patient we must mainly rely for an accurate history of the development of his illness, and such a history is often extremely valuable in determining its nature. Doctors need to know these things about your neurological condition in space and time. Space is what's happening in your body, and time is how have things changed from then to now. And doctors rely on the patient to tell them about these space and time occurrences. In the second place, many neurological conditions are purely subjective. It feels different to me, doctor. My tiredness is not your tiredness. They're abnormalities experienced by the patient and may be accompanied by no visible sign of the disease. Gordon Holmes wrote this about 80 years ago. He was a neurologist in the war, and he was known for being demanding but kind to his students. He wanted his students to involve the patient. And while he wrote that 80 years ago, it's really only in the last generation that we've seen an involvement of the patient in the training of students. It's no longer a patient lying in a bed with a group of white-coated men standing around them, talking in medical jargon about what's going on for them. The patient is much more involved. And to do that, to win that help and cooperation, doctors need to build trust. And trust is not something you read about in a book or learn about in a lecture. Trust is learned through real-life experiences. You learn to build rapport with patients when you have the experience of working with patients. You get better data from patients who trust you because they feel listened to and believed. You get better buy-in to treatment options because they trust you as doctor to do what's best for them. So we wanted to create a program, or Dr. DeLuca created a program, that would build the help and cooperation of patients, that would improve the medical education of students.
So I just want to give you a little bit of context into where this fits, because the way we teach medicine in the UK is different to the way it's taught in North America, and it's even different in Oxford. So I'm going to tell you about the Oxford medical degree, because this is the scheme that we're working with. So for simplicity's sake, I'm going to tell you about the standard traditional Oxford medical degree. So our students will do the first 3 years preclinical, which means basically book work. They're learning the biology, the physiology, the chemistry that they need to know. And there's very little patient contact in that. We're trying to change that, but I'm not going to talk about that today. And then they have the 3 clinical years. So for year 4, they will go and do general medicine and general surgery. But it's year 5 where our program sits in the brain and behaviour block. So brain and behaviour is neurology and psychiatry. That traditionally isn't taught together in the UK either. But hey, guess what? It's all the brain. So we've put it together, and we do 14 weeks with the students. They have 2 weeks of lectures. And then after their 2 weeks of lectures, Monday to Thursday of the weeks that follow, they do clinical rotation, so that can be outpatients and wards. And then the Fridays are teaching and professionalism sessions. And the program that we're going to describe fits into those Friday teaching sessions. And I'm just going to say the 5th year is kind of a mixture of all the specialties. So they also go through pediatrics, obstetrics and gynecology, family practice, emergency medicine. So it's a bit of a conveyor belt of going through all the specialties, and then they go and do some general medicine and general surgery at the end. So at the beginning of year 5, they've got a little bit of clinical experience, but by the end of year 5, we're looking at people that are almost ready to take their finals and go into their final year. So there is a spectrum of the people that we're teaching as well.
In that 5th year rotation and the brain and behaviour rotation, they encounter expert patient tutors. There are people who have a chronic neurological condition, multiple sclerosis, Parkinson's disease, or peripheral neuropathy. And these are chosen because they represent 3 distinct parts of the central nervous system. And don't ask me about what that is exactly and why that is. Gina will be able to tell you if you're curious. EPTs, as we're going to call them, are trained in how to communicate with students and how to give students an opportunity to learn about their own communication. We teach them how to engage with us as students, as medics. For instance, don't stand over me up here, come down to my level. Don't ask me something in jargon, put it in everyday language. And it's amazing how when you take something out of a book, it doesn't always land well with patients. So we're there to help them learn how to do that. We teach them how to touch patients, touch us, how to be firm and confident and not feather touch, which just implies you don't know what you're doing. How to gain confidence in moving somebody who is stiff or shaky. We give them opportunity to ask questions to us. What does this feel like? Is it okay if I do that? We give them feedback that is specific to the student, that is appreciative, you did this well, that is instructive, we would like you to do this like this, and it's constructive, When you do that, it doesn't work. So do it this way, and here's why. It's a safe place for them to try things out and to make mistakes. And we work alongside clinical educators because they link what students are seeing in real life with the theory they're getting from books, from lectures, from their interactions with the education. So we're trying to make it as holistic an experience as possible. So an EPT session looks like this. There are 3 zoned off poddy areas, and students will go around in small groups of 3 to 4 into these zones where they will meet a patient with one of the 3 diseases represented. They will also meet there a doctor who will be the educator. And in that session, they will have 5 minutes to get the story, the history of what's happened to you. The condition's not a secret, so it's not, guess what's wrong with me? It's, here's how to learn about MS or Parkinson's. They will then do a 15-minute focused, specific physical examination. So it might be of the eyes, the head, might be of the upper body, might be of the lower body, might be walking. And then they'll have 5 minutes of feedback from the EPT to them specifically, appreciatively, instructively and constructively. And then they move on. And I have to tell you that there are aha moments in these sessions where students who have never experienced what it feels like to move somebody who's jerky, they do it, they get what they read about in books, it happens in their hands, and they go, oh, this is what you do. Or a student who is really tentative about holding somebody's hand or foot properly, you teach them how to do it. Put your hand here, hold it like this, move it like this, and they go, I can do it now.
You can't learn this from a book. And what I should also add is that our expert patients are faculty. They're very much part of the teaching faculty. We run sessions as equals. I can never pretend to know what it's like, but equally I can guide the students with what they need to know to make a diagnosis. So we each bring something to the interaction. So we've cured neurophobia in Oxford, we believe. We've got some feedback. So the expert patient tutor session was perhaps the most useful learning experience I've ever had at medical school. I felt myself become more confident over the session. And this graph's a little bit small, but it does show. So it's how well did your year 5 course prepare you to attain the basic clinical examination skills in neurology to become a competent F1 or that foundation doctor or intern. And the red bars are before Professor De Luca took over the course, where it was the old course. There were no EPTs in the old course. And then you can see the rightward shift once we introduced EPTs into the new course. And EPTs, I mean, Rachel's been giving you actual real-time feedback, but some of the other feedback that we've had, I think one of my favourite ever pieces of feedback was, I'm sure that these sessions help the students put a name and a human face to the people that live with these diseases. So the story didn't end there. I think Josh told you about the coffee that he and I had about 3 years ago, pre-pandemic, where I was pretty cheesed off with some of my medical students for not turning up for something because it was a nice day outside. And he just coincidentally put together the Advancing Medical Professionalism report with the Royal College of Physicians. And this was set to address the gap between what doctors are trained to do and the realities of modern medical practice. Again, this is the stuff you can't get from a textbook, but it's the stuff that saves you in the middle of the night when you need to know what to do. And this talks about 7 aspects of the professional identity that we expect doctors to have. So doctor as healer, patient partner, team worker, manager and leader, learner and teacher, advocate and innovator. And these things, many of these things are not explicitly taught in medical school. So we set about putting together a curriculum. And I told you about how we brought neurology and psychiatry together, while we also added professionalism through the lens of the humanities with Josh's help to our programme. And I'm going to talk to you. Ariel spoke to you about our Death and Dying tour of the Ashmolean, and I'm going to tell you about our storytelling session with Rachel's help. And so this is the stories we hear, and this is the Faculty of History. Medical students have very rarely even know where the Faculty of History is. It's down by the bus station. It's a beautiful building. I love the Faculty of History. And it's where we decided to do our storytelling session. And we focus in this session around healer, advocate, and patient partner.
While these sessions were going on, the EPTs were also invited to join them, and then lockdown hit. And so the amazing team through the Ashmolean Humanities and the medical school brought the Ashmolean to us through these virtual coffee mornings and invited us to experience what the medical students were experiencing, to go through it and see it through their eyes, but also to co-create the curriculum to be developed in the future. Is there anything that is missing from this as patients? So there were a few areas that as patients we identified through these coffee mornings as being essential and important for students to learn in order, remember, for them to grow in confidence and competence so that we don't lose them before they've started. And these were addressing advocacy and the role of the patient support network. Patients are in social networks, and the neurological condition affects every part of it. Like a web, a spider touches the web and the whole thing vibrates. There are vibrations throughout the whole of the network. And so we need to be conscious of what that network is experiencing. And when patients come to a consultation with a doctor and they bring a companion with them, that is the third person in the room, who is sometimes representative of the social network. Sometimes it is the only person they have in their life. EPTs wanted to remind us of the impact their condition has on the family network and how they too are affected. Patients are affected, are supported in physical ways, emotional ways, decision-making ways, and doctors need to be trained in skills in how to involve these networks in the clinical discussion. And so we wanted to develop a way for students to grow in their skills, not just in interacting with the patient, but interacting with their network. And this is where Gina and others developed the EPTC program, the Expert Patient Tutor Companion Program, listening to the patients and their companions to hear the whole story and get a whole picture.
So our hypothesis is that appreciating the importance of consultation companions will lead to more holistic, effective practice that will benefit patients and their companions. So the learning objectives for our session were, because we're teaching through the lens of the humanities, to apply narrative skills when taking patient histories, to understand the perspective of patient companions, which I'm going to focus on in a minute, and to appreciate the importance of what we're terming a collateral history, and also to develop narrative skills for effective reflective practice, which we all need to do as clinicians. What I neglected to tell you on the slide where I had the what Oxford Medical School looks like is that we have 160 students in each year and we get a third of them for this session. So it is a bit of a logistical nightmare trying to sort them all out. But essentially we split them into two groups of 30 and then they spend time much in the same way as they do with expert patient tutors, but with their significant other that they've brought with them and a group of students. And what we teach them is taking a history. So the traditional history is a patient and a doctor what's brought you to see me today? Where's the pain? When did it start? How bad is it? Have you taken anything to take the pain away? And it's very centered on the person that's in front of you. But quite often, and it happens in my clinic all the time, they bring somebody with them. And that is their companion. And that companion is a very important person in their life. And that companion knows your patient better than anybody, and actually better than the patient themselves sometimes, because there are certain things that patients themselves may not notice. Maybe it's their memory, maybe it's taking them a little bit longer to get to the shops than it did before. And the person that lives with them or that knows them really well that they brings that extra bit of the history that is so vital to knowing also what that patient support network is like. And when I'm doing these sessions with the students, I say it's very important to know who's at home, because if you admit somebody to hospital, the person at home, they may be the carer for the person at home as well. So you really need to understand the broad network. So what we do is we take a collateral history. I don't just talk about the patient with the third person in the room. We do it together and we have a conversation. I say sometimes, do you mind if I ask your partner this question, for example? We teach the students a way of communicating with everybody that's there, and everybody that's there with the best interest of your patient in front of you. And that's what we're calling a collateral history. And we can think about this by thinking about how we read narrative. So there's a character, there's time, there's plot, there's subplot, there's setting, and there's secondary characters. And when we're thinking about teaching the students how to communicate, not only with their patient, but the other person in the room, I want them to think about these aspects and how that's applicable so that they don't forget to ask anything or consider anything. And we can apply it to our patients. So the main character is obviously the patient. That is the most important person who you're treating. The time is their presenting complaint. Why have they come to see you today? The plot is what's brought them to the point of coming to see you today. The subplot is the comorbidities. So do they have diabetes? Do they have thyroid problems? Do they have other medical conditions that if you treat one, you might make the other worse? You need to understand everything going on. Their additional worries, work stress. Thinking about the setting, the spaces, the environment in which they inhabit. Traveling, that might be important. You may need to help them in order to make that possible. You may need to provide a letter or things like that. I always say to my patients with MS, it's about living with MS, but MS should not dictate to you what you do. And you can only understand what's important to a patient by speaking to them, but speaking to the people that are in their support network. And that is the secondary characters, the family, the colleagues, the friends, and the medical staff as well. And I asked some of our EPTCs and our EPTs about, because this is we've only been doing this for a year now, but what they felt having done a year of the programme. And they thought that it was lovely, because they often feel that in clinic appointments with qualified doctors that they're just ignored, not even acknowledged. You don't even ask what their name is. And I think some of the feedback that I've got from the students is, oh yeah, we're actually going to ask who else is in the room, which is actually really important anyway, and it's a really basic skill. But the patients and the expert patient tutor companions, they like to be acknowledged, and actually the chronic condition affects the whole family in different ways as well. And it's about letting that family being able to do what they want to do and getting on with their lives, and their MS is just a part of that. And they see them as a person, so seeing the person behind the disease, but the person behind the disease, that is important to other people and has other roles and has careers and things like that. You need to understand all of this in order to give effective treatments. And also, if there are memory problems or problems with walking, etc., it might be the person in the room that's helping take notes and helping remember what you say in order to manage that patient's condition. And we have a mother and daughter that come, and the students find that especially beneficial because they've never really thought of having, or some of them obviously maybe have this in their lives, but the majority of them have never thought about what it's like to have a parent with a condition as well. So that was a whistle-stop tour. I hope you're all nice and clear now. If we give you all the EPT, EPTCs. We're talking about how can we retain medical students? How can we better prepare them
for their work as a medical professional. And we want to improve their competence and their confidence at medical school so that they are less likely to stumble before they've really started walking.
And it is really about if a patient doesn't feel that they can talk to you, you're going to miss things. You're not going to be a safe practitioner. And these things are often called the non-cognitive skills in medical education. I think it's probably some of the most cognitive stuff you can do, actually. And I just find it's a privilege I learn something. I've been qualified for 15 years. Every time I do a session, I learn something that changes my practice. So it's not just for the students' benefit either. So our acknowledgements, Professor Gabriel De Luca, whose idea EPTs was. Sally Bromley is an EPT that came up with the idea with Professor De Luca, but Sally represents all of our EPTs and EPTCs, and we've actually, I hope you don't mind me pointing, but we've got Bron, who helps us out at the back, and Derek as well, who've come along and they've been hugely influential in our curriculum, and we couldn't do it without them. We have to teach patient-relevant things. You need to ask the patient in the room. You can't just talk about them. Marie Allett was our previous humanities fellow who was very into narrative medicine. So she designed a lot of the course. And also Luke Austin, who also happens to be here, who went through the EPT programme, but also designed part of the storytelling session as well. I don't know, Luke, if you wanted to say it.
Sure, I think 2016 I actually must have been the first Bekos to do it. Back then, neurology and psychiatry was still separated, but yeah, I mean, what could be more patient-centered than bringing the patient into the classroom from the get-go, compared to the traditional paradigm of you stay in the classroom in the library and you have to be encouraged, and then you go to the walls. But actually, bringing the patient right into the beginning.
Thank you. And then the whole team for advancing medical professionalism, which storytelling is part of it. Thank you for listening.